This is a conversation on pain provocation tests and injection studies, and this comes from chapter 5, which is titled SI Joint Dysfunction. And there are a series of pain provocation tests that you're probably already familiar with, and research has shown that these various tests correlate with reduction in pain with an injection into the sacroiliac joint. And the conclusion from those studies is that performing these pain provocation tests, if 2 or more are positive, including a thigh thrust test, then there's a high probability that the pain is coming from the sacroiliac joint. And these tests are primarily hip tests, and we'll discuss them again in a separate section specific to the hip. But I think that they need to be interpreted very cautiously because forces certainly go through the hip, and the fact that the hip has a similar innervation as does the sacroiliac joint, and certainly they're very proximal to each other. And I have a few YouTube videos on the subject, and I've demonstrated that a client may have isolation of forces going through the SI joint such that you feel deformation with your fingers placed just medial to the PSISs, palpating the sacroiliac ligaments and proximal soft tissues. And that may be isolated in one individual with the hip flex 90 degrees, and in another person you may have to flex it much higher and adduct it before you are isolating that part of the structure. So I think that there's a lot of unanswered questions with respect to these pain provocation tests. The studies on injection shed further light on that, and there are at least 2 studies that demonstrate that an injection, not in the joint, but in the retroarticular space, as compared to a population in which it's performed inside the joint, actually has a better outcome in terms of pain relief, and that some of those who have injection into the joint, it can bleed out anteriorly if there's a rent in the capsule, which will then bathe the lumbosacral plexus and of course relieve pain, etc. I think another noteworthy point is that in one study, after the first injection, 50% of those folks dropped off when a second injection was performed and did not yield the same relief, the same benefit. And it could be technical issues, or it could be the fact that Mother Nature, our body, likes something innovative and is impressed with new stimuli, but then on repetition of that stimuli no longer has the effect. Those are just general conclusion, and there certainly is more and more literature coming out with respect to the injections. There's another study that demonstrated a large percentage of people who were previously diagnosed as having sacroiliac joint pain had pathology of the hip joint. And I have yet to see screening of the hip as a part of the screening process for sacroiliac fusion, and I think that's a significant gap in the field at this time. When we get to treating the most common pattern, we'll discuss 3 precursors that have to do with gross pelvic motion, and 2 patterns that are commonly restricted in our population in the hip joint, and those are always treated first. And some of these concepts are repeated throughout, and some of these have been introduced earlier. And on the topic of pain, there is, of course, that issue of pathological instability, which typically has a distinct signature in radiology in which there is a gapping in the SI joint which is readily apparent, being greater than 2 millimeters, and also a greater gap at the pubic joints. There is a gray area where clients seem to fit into the sacroiliac diagnoses, but have similar presentations as other people with hip syndromes and low back pain. So there isn't a very lucid, absolute definition of what SIJ dysfunction presents with. It actually presents with similar to folks with hip pathologies, as I stated, in lumbar spine. And for that reason, we need to be cautious about our conclusions, and certainly cautious when we're referring for a workup for possible instability. And pathological instability most certainly is not asymmetry of pelvic landmarks that can be corrected short term but does not correct long term. That does not represent instability of the joint. So that serves as a brief introduction to pain in the sacroiliac joint, and our next chapter is going to be chapter 6, which is Principles of Manual Therapy. Thank you.